To start with our first session of week 2, I'm proud to introduce one of my close mentors, Dr. José Mayorga. He's a board-certified family physician leader with extensive professional experience in the for-profit and nonprofit sectors. He has dedicated his family medicine and administration career to providing high-quality care to the medically underserved. Dr. Mayorga's career in medicine began in 2008 as a per diem physician. In 2010, he opened his own private practice and was also a site medical director for UltiMed Health Services, the nation's largest independent federally qualified community health center. In 2021, he became the chief medical officer of Share Ourselves Corporation. And then in 2015, he became the IPA medical director of Healthcare Partners, a division of DaVita Medical Group, now Optum. Since 2018, Dr. Mayorga is the executive director of the UCI Health Family Health Centers and is faculty in the Department of Family Medicine at UC Irvine. In July 2018, he joined UCI Health Department of Family Medicine as an assistant clinical professor. He leads the UCI Health Family Health Centers, the oldest FQHC in Orange County, as their CEO and CMO. And he's excited to return to the clinic where his passion for underserved medicine began as a student 23 years ago. In 2020, the UCI FQHC cared for 24,000 patients who were predominantly Latinx and monolingual Spanish speakers. 99% of the patients live below 200% of the federal poverty level. Of those served, 32% are children. He believes the safety net network of care is the best kept secret in healthcare and is committed to making community health centers the medical home of choice. He's a lecturer on various topics, including population health and social determinants of health, and he'll join us for 2 different sessions during this elective. He served as a COVID-19 medical expert in English and Spanish media outlet in town halls in Orange County. And he looks forward to teaching the future doctors of this country and hopes to empower them to become leaders in primary care and advocates for health justice. Welcome, Dr. Mayorga.
Thanks, Kelly. It's an absolute pleasure being with you guys today. And I thought I'd start off by, allowing Kelly to show me her Lakers backboard back there. I see it, by the way. I'm a huge Laker fan. So there it is. Yeah, thanks. But hey, I am excited. This is the second year I've been invited to do this elective, and I will be doing a few lectures. This one's interesting for me because it'll draw on a lot of my experience outside of the academic realm, more so when I was in private practice, as well as being the IPA medical director. And what does IPA mean? Well, you're about to find out because there's a little bit of education behind that. So what I would like to do is I'm going to start sharing my screen. This is an interactive conversation, so definitely want to make sure you guys pose questions. The team is monitoring the chat for me. And so really what I'd love to jump into is talk to you about something that's super complicated for a lot of folks. And I want you to put on the lens and think, if you can, think for me that you are 65 years old or older, okay? And this is really important. You probably have loved ones. You probably have grandparents. Some of you may have great-grandparents who are this age. So really think about it through their eyes as you're listening to what I'm about to take you through, this adventure, and to some extent, I'm going to say kind of scary adventure known as Medicare. So true to form, there's a beautiful road there. You got to choose your adventure. Which path do you take? They look pretty much the same, right? But what I'd like to kind of look at it a different way is I'm going to give you some Medicare Insurance 101. So hopefully you'll learn something not only with regards to how healthcare is being delivered in this space, but also maybe you could share some of this knowledge with your loved ones who may be in this now or soon to be. And then, of course, I'm going to throw in a little bit extra information around managed care, the infamous HMO concept. So we'll talk about that. So why don't we go over the 5 bullets that we're going to try to cover today. So we're going to give you a quick history lesson on Medicare. I'm going to talk about the Medicare Alphabet, or alphabet soup. I'm going to talk a little bit about the differences between Medicare fee-for-service and Medicare Advantage, also known as MA. And then I want you to kind of look at it again from an importance of being a patient. And then if you all were physicians or working in the healthcare space, what is important to you to be involved in Medicare or managed care? So I'm going to give you two different perspectives on how to look at this. And then lastly, of course, I mentioned we're going to talk about managed care itself. So just like everything I like to do, I like to pose some questions just to kind of get the wheels spinning in our heads. So why don't we start off with our first poll question? So you should be seeing the poll question popping up, and it should state what population does Medicare serve? So what population does Medicare serve?
So it looks like we have some responses coming in. I'll give our audience a few more moments to submit their responses.
All right.
All right.
Take your best guess.
Okay. It looks like we have 15 so far. So if everyone wants to toggle to my screen, just as a reminder, you should have an option when you go up to the top. And then you can choose my screen. I'll show the results. So the majority of people put 65 or older. We have some, about 20% said end-stage renal disease, as well as permanently disabled. And then it looks like we got a couple of votes, 5% who said low income.
All right. Okay, keep that in mind. Remember your answer. So let's go on to another quick question, okay? True or false question. This one's pretty straightforward. Just shoot from the hip, right? Always go with your gut. With Medicare, patients don't have to pay for anything out of pocket. True or false?
Okay, so the second one's activated. We're getting a response pretty quickly. We have about 8. And majority of people said false, about 90%.
All right. Okay, so let's go through history, right? I love history lessons, especially when it comes to certain things that are really important to me. So some of you may recognize this gentleman. This is President Johnson. He's actually really important to us all in healthcare. He is responsible for two really important pieces of legislation. The first, which you see here in front of you, is signing into law back in 1965, the Medicare and Medicaid bill. The other thing that, if you join me in about another hour, I'll mention another really great, exciting thing he put into law. So I'm going to, leave you hanging there, and hopefully you join us. You'll see probably this photo again. But one of the things that Medicare was established back in 1965 was for people to have health coverage over that age, because at the end of the day, they couldn't afford their insurance coverage. They couldn't afford private medical insurance at the time. 56%, as a matter of fact, couldn't afford it. And if you think about what was going on in 1965, there was a very different perspective on how health was being delivered. Most of the care was being delivered inside a hospital, right? There wasn't outpatient surgery centers. There weren't same-day surgeries being done. Everything was being done inside a physical building. And so the cost associated for folks was immense. And so the other thing to really appreciate is, there wasn't much to do about what was quality-based care, what were some metrics, or you hear these terms of, evidence-based, quality-driven healthcare. Those concepts weren't being discussed at the time back in 1965. And, just to kind of give you some perspective, even when he signed this in 1965, this wasn't the first time the U.S. or a president proposed a national health insurance. As a matter of fact, President Truman, Harry Truman, asked the country, asked Congress and Senate to consider back in 1945 universal health care, if you want to kind of call it that, or national health insurance. So it's really important to kind of put things in perspective, again, as we're living and breathing all these changes in our government, how long some things really do take. And so, again, I think it's really important. And then the other thing that really stands out to me with regards to President Johnson was this. Think about what was going on in the 60s, right? It was the Vietnam War. There was massive amounts of energy and money being pushed into the military. But this was a very famous quote that most folks have not heard before, but he really said this, and he didn't want to sacrifice the money that needed to be provided for health. And so he was willing to do it for defense, but not for health. So again, really kudos to President Johnson in signing these bills into place. Now, what is, and one fun fact I will say is, remember I mentioned President Truman was the first back in 1945 to push forward Medicare or the national health care. Guess what? Him and his wife were the first Medicare enrollees. So that's just a really fun fact to share with you all. So what is Medicare? So let's kind of give you some broad strokes, right? We pose this question. So Medicare is health coverage for those over the age of 65. If you're under 65 and receiving Social Security disability insurance for certain types or for a certain time frame, you are also eligible. And then for those under 65 with certain debilitating diseases such as end-stage renal disease, or also something known as ALS or Lou Gehrig's disease, that is also makes you eligible for Medicare. Now, Medicare is funded by the Social Security Administration, which means it's funded by taxpayers. It's approximately 0.45%, so 1.45% of earnings go into this bucket. And employers also chip into this, approximately 1.45%, which makes it a total of 2.9% coming out of wages and earnings of various companies as well as us as employees. So really, the other thing that makes it really important for us to understand about Medicare is you have to actually contribute into it. So if you work in the U.S. and you've had any job, typically you're paying into it, right? You see that little line, and so you need roughly about 10 years of work or 40 quarters of work to really take the full benefits of getting Medicare health insurance coverage. So again, all really perspective. So we're gonna go through some alphabet soup, but before I do that, I mentioned earlier that we were gonna kind of discover what's Medicare fee-for-service versus Medicare Advantage. So we're going to go to another quick poll question. Again, do your best test-taking techniques here. So I posed to you some questions there for which one represents the best answer, either original Medicare versus Medicare Advantage. Reese, are you there?
Yes, so if everyone could, we're getting some answers come in. We've gotten about 4 for the first question. Once we get up to 5 or 6, okay. So let's see what people's response was for dental. We have one person that said part C, Advantage.
Okay.
Another person said Advantage. Original, Advantage.
All right.
Mostly Advantage, it looks like. Oh, I have no idea. Oh, someone deleted that.
All right. Why don't we jump on to the next question? So what plan has limits on out-of-pocket costs? The key phrase here is limits, okay? What plan has limits on out-of-pocket costs? Is it original Medicare? Or is it Medicare Advantage?
So the new question should be active. We have run response. So one person says Advantage. I'm assuming the person who typed in A meant Advantage. We have another person who said no idea. Medicare Advantage for the cost limits. And that seems to be our responses so far.
All right. And then the last question is, why don't we jump to the last question here, which is, which plan is more beneficial to seniors with a fixed income? So which plan is more beneficial to seniors with a fixed income? Again, use your best judgment on these questions, and you're definitely going to answer all of them.
So this new poll should be active for everyone to answer. We've gotten a couple responses. I'll share our responses once we get up to 5. How about that? So far we have 2.
So
Still only have 2.
original Medicare Advantage.
3. Oh, someone deleted the response. People may not know this one as well, assuming based off of our hesitancy in responses. I'll show them so far. We have original Medicare, Advantage, original.
All right. Well, hey, listen, and this is why we're having this conversation, because these are questions that a lot of people need to be able to answer. And so why don't we take a tour of this alphabet soup? Because I think it's really important. And again, look at it from the lens of being a consumer, being someone about to enter this eligibility of Medicare. So why don't we jump in? So Medicare Part A. Part A is hospital insurance. So it's considered, this is considered the original Medicare, the traditional Medicare, which will be coverage for unexpected injury, a sudden illness that requires you to be admitted to a hospital. And so for some people, it tends to be free, and I put that in quotations, free, because not anything is free, right? Because we've paid into this. But also, take a look with that next bullet. It says deductible. What is deductible? What does that mean? Well, deductible is a set amount of money one pays for medical services. Okay. So, for example, I would have to pay in 2021 about approximately $1,500 before my co-insurance kicks in, i.e., in this case, Medicare. So that co-assurance doesn't necessarily mean that they're going to pay it all. It means that they're going to pay a percentage of the cost. So I'm still going to be left responsible for a certain amount. So let's put this in perspective. If once you meet that deductible and the co-insurance now is willing to pay, if something costs you $100 and your responsibility is 20%, you'll have to pay $20. So the other thing that's really interesting about this for Medicare recipients is after 60 days of admission, so the entire year, so think about a calendar year. If I get admitted to the hospital 60 days, after that, this insurance doesn't necessarily cover you anymore. So you'll start having to pay more. So again, really interesting dynamics when it comes to the way this is structured. And then that last bullet is probably the most concerning for me and hopefully for you when you look at it, is there's no max expense. There's no limit. So you could continue to amount bills to have to pay. And so there is no limitation on your out-of-pocket expense for the entire calendar year. So if you get admitted to the hospital 45 days, you still continue to have to pay that. If you get admitted past 60 days, you pay even more. So again, really, really impactful. So what other coverage does Part A provide besides admission and care inside a hospital? It also covers skilled nursing facilities, and it can cover some home health resources as well as hospice. So this is kind of that bucket, okay? So this is Part A. So let's go on to Part B, which is probably one that's more near and dear to my heart because I'm a primary care doctor. This is all outpatient based. So Part B is your coverage for healthcare visits to help you stay healthy or manage your chronic diseases. So this covers your doctor's appointments. This covers ambulances, your labs, your x-ray imaging, some home health, and some medical equipment and supplies. Now, there is a premium. In other words, you got to pay a certain dollar amount. And if you're a Social Security benefit individual, guess what? That $148.50 comes out of your Social Security benefit every month. It can go up as high as in the 400s, but the base minimum is $148. So if you think about it from an insurance, you are paying for insurance now. So there's the Part A that we talked about, but then you also need to speed, right? You want to stay out of the hospital, so you want to be seen by by a doctor, and most of our 65 years and older individuals do require some ongoing medical management, right? And so really, really important to understand, again, there is a deductible associated. It depends on the way it's structured. In other words, you have to pay a little bit more depending on the type of setup you have. And again, there is no limitation. Your out-of-pocket max expenses continue to rise. So if you happen to be someone that has multiple chronic medical problems and have to see lots of specialists throughout your calendar year, those continue to stack up and will cost some money. So I think it's really important to appreciate that. So that was part A. That is part B. So now let's jump to part D. So this is something, again, one has to think about as a consumer, as a patient. You have to get prescription coverage, right? It's not included in part A. It's not included in part B. And if I prescribe you a medication, well, you have to have part D coverage. And so this is part D, is this prescription drug coverage. And it's, again, very important. There's monthly premiums, right? So not only are they taking money out for your part B, right? We just showed you it was roughly about $148, I believe. But now you have to pay coverage for medications, right? So there's approximately $35, but that varies. And so the way these prescription drug plans are structured is very varied. So one could be a flat rate. In other words, you pay $10 for a slew of medications ranging from, for example, generics. You just pay a flat rate of $10 for your prescription. Or in other situations, you pay a percentage of the prescription cost. So if the drug costs $100, you may owe 20%, so you'll pay $20 for that monthly prescription. So again, those are really important things to appreciate. Now, those last bullets should really concern you. They concern me because if you reach $4,130, I don't know how they come up with these numbers, but they sure come up with some kooky numbers. If you reach $4,130, at that point, combined, meaning you paid that much and so does your insurance coverage. Moving forward, you're responsible for your ongoing prescription costs, approximately 25% for the remainder of the calendar year. Okay, that's a really important point. So yes, think about our elderly. They have multiple medical problems. They're on multiple medications. They've hit this $4,130 combined collectively. Again, this is really important. Collectively, the drug plan and you paid that $4,000, and now you are on the hook for the remainder of the cost of your drugs, 25% for the rest of the year. Now, here's where it gets confusing. You could get catastrophic coverage if you yourself as the patient have in 2021 paid out of your own pocket $6,550. At this stage, all you're now responsible for is 5% of the remainder prescription drugs for your year.
So Dr. Mayorga,
Yes, sir.
we have our first couple of questions in the chat. So Sarah asks, what happens if you're very low income and you can't pay these premiums or deductibles?
That is why I'm driving this point, because think about who is eligible, who are our Medicaid recipients. These are mostly our elderly individuals who are on a fixed income. They're on Social Security, okay? And we haven't even talked about those that are really have challenges from a financial standpoint. But you're absolutely right. So from a really disadvantaged, and I am going to use that word here, disadvantaged standpoint, think about being a senior, having to mitigate your monthly expenses on a fixed dollar amount, and you have this potential impact. If they see me as a doctor, and now I have to adjust their medications, I just add another medication. That just adds to their overall cost of care. And that's an unfortunate situation because think about all the wonderful drugs that are out there. There's definitely generics that work really well for our patients, but then there's some need for branded drugs, right? Some drugs that just recently come out. Those are not generics. Those are expensive drugs. So again, it's very disheartening to think of some of the challenges our patients encounter. And this is why it's important, as many of you are in the health field, to appreciate the impact that we have every time we write a prescription, every time we electronically send a script or sign one. This is something to keep front in mind. Reese, you have another question?
Yeah, that kind of led into the second question as well. We have another student, Joanna, who asks, I know private health insurances refuse to cover certain medications dependent on whether or not a patient has an expensive condition. Does Medicare do this as well with specific medications?
It can, John, it actually can, and I think it's really important to appreciate that there are certain drugs that are not covered, and as a physician has to advocate for their patients, submit what's known as a prior authorization, not only to insurance companies, but even at times to Medicare, and say, this is why we're trying to justify the use of this medication. And so if you look at it in a different lens, using medications off-label is not necessarily a good thing. There are, uses of certain medications that are labeled off-label to use. You want to be cognizant of that, because at that point, that patient will probably be on the hook for the entire cost of that drug. So it's again, really, really important. And again, my heart goes out to these patients all the time, because these are things that we don't get taught. We don't tend to appreciate the ramifications of prescribing drugs to our patients. Because to me, this is probably the most costly aspect of their care. And all we're trying to do is keep them out of the hospital, right? We want to keep them controlled and healthy as best as we can to keep them out of the hospital, but yet drugs are really, really expensive. Any other questions, Reese, before I move on?
Doesn't appear so at the moment. Thank you, though.
Okay. Yeah, no problem. So let's talk about the last letter in the alphabet. Let's talk about Part C, also known as Medicare Advantage. Now, you guys were answering the questions, and you did some great test-taking. You kind of looked at the word. Hopefully, you said, well, there's advantage on the second part of that. It has to be better, right? So hopefully you looked at it in that lens. That's how I would have approached the question if I obviously didn't know the material. But Medicare Advantage was established by President Clinton back in 1997. So really what it takes together is Part A, B, and for all intents and purposes, it does include D. Okay, so it takes the whole package of Medicare, A, B, and D. And usually there's lower deductibles, there's lower copays. What does it cover? It covers everything in A, B, like we talked, right? So hospitalization, outpatient services, and drugs. The other thing that Medicare Advantage tends to offer is they do a lot of preventative care. They offer oral or dental health, vision, hearing, transportation. Believe it or not, health club memberships like to 24-hour fitness, those types of things. It will cover some international coverage, so worldwide emergency coverage. And the other component that most folks don't really tend to appreciate is the care management. Care management, what does that mean? Care management is a designated nurse to help navigate these patients through their continuum of care. So remember, these individuals may have multiple chronic conditions that require specialty care. So they help kind of move them through the continuum of care in certain aspects, depending on how complex they are. And so the other thing that's really unique about Medicare Advantage is it's a very limited time that you can sign up for it. Most individuals are eligible to sign up and switch over from the traditional Medicare to Medicare Advantage during the months of October to December for the following calendar year, okay? And so you can disenroll, you can opt out And I'll explain why some people do that in a moment. But then the other thing too is, what if I'm turning 65, or I'm 3 months away from turning 65, I could enroll then, or 3 months after I turn 65, I could enroll in what's known as Medicare Advantage. The other thing that's a little bit of a nuance, and we won't get too much detail into it, but there is something known as Medicare Medicaid, or Medicare Medicaid. Another way is Medi-Medi. There's no restrictions on changing your plan. You can go back and forth. You can go into Medicare Advantage. You can come out of it if you have that designation. Again, it would be a designation of Medi-Medi, or Medicare Medicaid. So what's so unique about Medicare Advantage? I mean, you've heard a lot about it so far, but let's kind of look at some statistics around Medicare Advantage, since President Quinn's era. So back in, if you're looking at the map here, you can see the majority of the states that tend to be the larger states that have a lot of enrollees in Medicare Advantage. In 2018, 1 in 3 individuals who were eligible for Medicare actually enrolled into Medicare Advantage. It's now at about, in 2020, around 39%. And so what's really interesting, remember we talked about out-of-pocket limits, right? We mentioned that word limit. It's really important. In 2018, the out-of-pocket limit for combined Medicare A and B was just around $5,200. Okay, so that's pretty reasonable if you think about what I shared with you a minute ago, that there was no limit if you went the traditional route, right? So I think those are some really important points to appreciate of how this all works. And so this is kind of a bar graph of the years of trends. You can see in just a decade, from 2010 to 2020, it's more than doubled into enrollees. And so that's a really exciting point. There's some interesting things about, why isn't more people enrolled in Medicare? Why aren't all of our seniors or those eligible for Medicare enrolled in this? Well, let's talk about why that might be the case. So what's in it for the patients? Okay, so now we're all patients. We're all thinking about this, trying to make a decision. What's really interesting is the advantage around this is there is a copayment. It's cheaper, right? We talked about that in comparison to, so it's cheaper than the more traditional Medicare cost part A and B. We talked about the additional benefits. But here's where people start getting a little nervous. Okay, this is why we don't see more enrollees, is because now the primary care physician, like myself, is responsible to be the gatekeeper. So everything funnels through me. Everything funnels through our primary care physician. So if someone needs to see a specialist, we need to refer them. We need to see them. We need to evaluate them, and then make the decision to send them off to referral. And if I do send them to a referral partner, a specialist, it has to be in network. It has to be a specialist within that Medicare Advantage program or insurance carrier. And so for example, if I'm a senior patient and I have my cardiologist Dr. Vasquez, and Dr. Vasquez is not in my Medicare Advantage program, am I going to transition into Medicare Advantage, or am I going to stay with Dr. Vasquez? So those are some of the nuances behind Medicare Advantage when it comes to all this. People are making decisions based off potentially who they're able to continue to see for their care. And you can imagine, right, people have relationships with their doctors. They like one, and they're not always sure that that individual is part of that network. So those are some really important points of what's in it for patients, and why not a lot or larger proportion of people are enrolled. I think these last two are the really key points. I'll say one final point on this slide here is, if you're in Medicare fee-for-service, in other words, that Part B that we talked about, right, letter B, you can go to a specialist without a PCP. I could go see Dr. Vasquez. I don't have to go to my PCP. Or I could go see my nephrologist or my neurologist. I could just pick up the phone and make the appointment. I don't need a referral if I'm in that program. So let's see, what else is in it for patients? This is actually what I really like, and a lot of people don't realize that this is available to them. But there's public information about Medicare Advantage programs. Patients could access how good this program or this health plan is or medical group is in taking care of their patients. So this is really good information. This is public data. Every single health plan wants to be 5 stars, okay? Every single one wants to be 5-star, and they're rated that way. Medicare Advantage programs, they're rated on 5 stars. And so, what is it that they talk about? These are the 5 areas that they're rated on. They're rated on being able to keep people healthy. In other words, are they doing routine screenings? Are they doing those mammograms, those colorectal cancer screenings? Are they getting vaccinated? Are they getting their flu shots? How often are they doing your annual wellness visits? Are they managing chronic conditions well? So are they managing that diabetes, hypertension, COPD? How responsive are they to caring for those individuals? That's really important. And then are patients having a good experience? They're actually rated. Like, do you really enjoy going to see your doctor? Are the staff engaged with you when you get there? Those things are really important. And then the last piece that they're rated on is customer service. If I call the health plan, how quickly do they respond? How quickly do they answer their phone? And how responsive are they to my needs? And so every Medicare Advantage health plan or medical group really strives to be a 5-star entity, because in the end, that really makes a huge difference. And trust me, there are not many 5-star health plans out there. So there's, at least locally, I would say that the 5-star entity around us is Kaiser. Kaiser gets an overall grade of 5 across the board of all these 5. Other people have a potpourri of scores, anywhere from 3 to 4 to 5, but Kaiser really hits the mark on all these at 5. So what's in it for you? So let's flip it around. If you are all physicians, I'm a physician, what's in it for us as clinicians, right? So now, I have a panel of patients that includes Medicare Advantage plans. And this is a really important piece, right? So Medicare Advantage is really unique. I get paid for, if I am assigned 200 Medicare Advantage patients, I get paid on a monthly basis if I see them or if I do not see them. Okay, so I get paid a certain dollar amount. And some of that dollar amount could be as high as like $150 a month. So you do the math, right? 150 times 200 people, that's a good amount of money if I don't see those patients. The other thing is that I really like is there's patient support. So remember I mentioned care management? So I have a complex patient, and that patient requires some additional care navigation, and I'm a private office. I only have a front desk person and a medical assistant in the back with me. Well, if this patient has a lot of complexities, I need some assistance. So I'm able to refer them to care management. They're able to help me navigate that patient through the continuum of care. The other thing is, doctors like to say that they are high standard, they do high standard, high level of care, and so we are held during Medicare Advantage health plans to meet all those 5 stars, right? Specifically the chronic disease management, patient experience, and preventative medicine. That's how the health plans engage us as physicians to ensure that we're achieving that, because they don't achieve that 5-star if we can achieve it at the local level in the clinic office. So I think it's really important to kind of appreciate that. The last bullet is compensation. So we talked about payment originally, but then the next piece is, if I achieve good patient experience, if I achieve benchmarks when it comes to quality evidence-based medicine, chronic disease management, and preventative measures, I could get additional money from that. I could get bonuses for that. And so that's a really important thing. to kind of appreciate what's in it for physicians when it comes to this piece. Now, you would think that all this is really important, so why wouldn't, again, more people sign up for this? If I am the health plan now, if I put on my health plan hat, if I am Blue Shield, and if I am Cigna, if I am Kaiser, okay, how do I make money behind this? So here's the business aspect of medicine. They make money by being able to control the cost of care, but still doing it well, okay? So back in 2018, Medicare Advantage plans received $6.3 billion in bonuses. That's an average of about $320 per enrollee. And one of the interesting pieces of legislation behind Medicare Advantage is that they have to take the vast proportion of that money and actually reduce premiums, provide extra benefits, i.e. Hearing, vision, transportation, like we talked about. They have to utilize that. Of course, they get to keep a percentage of it, but usually that percentage is not higher than, roughly it's about like 10 to 15%. The remainder of those dollars have to go right back into somehow managing the patient. And most of them drive it around that care navigation piece that I mentioned earlier. And so they're able to sustain that. So this is why a lot of health plans really push towards a Medicare Advantage model, simply because they're able to control costs in a very, very specific way, by still being able to navigate and do good health care. And more importantly, it's transparency, because at the end, the higher rated star you are, the more likely you're going to get patients to join your health plan. Questions there? Any questions or comments about what we just covered? Good.
I haven't seen any come in the chat yet, but chat box is open for those that might be curious. Okay, here we do. Here we do. What does that bonus incentivize, Dr. Mayorga?
Yeah, so the bonus for the health plans, let's go back to that. So you know, let's kind of look at it a very unique lens, right? So I'm a primary care doctor. I am a family physician. You would hope that I wouldn't need to be incentivized to do colorectal cancer screening for patients that are eligible and need it. Or you would hope that I wouldn't need to be incentivized to drive diabetes care management at goal. But those are the incentives at the provider level that are incentivized. At the health plan level are also incentivized. Because you got to remember, these are thousands upon thousands of patients that are enrolled within the health plan. And so their goal is to make sure that they can manage the population, right? They are given a population of patients to serve and care for. And the goal is to keep them healthy and mitigate the healthcare costs amongst that population. And so that's a really important point, and that's why they incentivize it, because in the end, they're able to demonstrate better cost of care and better health outcomes. Other questions? Good? All right. So let's kind of transition over to, now we're going to pivot, right? So we talked about Medicare. We went through the alphabet. We went to the difference between traditional, or Medicare fee-for-service, I should say, Medicare fee-for-service versus Medicare Advantage. And really kind of looking at it through the lens of our elderly patients and some of the challenges. I wanted to make sure at least I touched upon other things that are important, because all of you at some point may be exposed, either yourself are enrolled in this, or you're going to be caring for patients within HMO and IPA or health network. What is all this? What are all these words or acronyms mean? The short answer is this. Yep. Oh, there we go. Sorry. Forgot that there was animation there. The short answer is this. An HMO equals an IPA equals a health network. So an HMO is a health maintenance organization. An IPA is an independent practice association. They're all one and the same. They're all health networks. Now a health plan health plan, i.e. United Healthcare, Health Net, Blue Shield, Blue Cross, that health plan, they contract with an HMO, IPA, or a health network. Now, these are medical groups or health networks, such as where I used to oversee at DaVita, which was Healthcare Partners. So that was a health network. And so the health plan, the insurance, says to the health network, we will assign you X number of patients or lives, and we're going to ask you to manage their care for us in order for us to achieve overall outcomes and control and mitigate costs, right? And those health networks ultimately make the decision on how to manage those patients. Again, this is going to be some of this is going to look very similar to what we talked about Medicare Advantage, but that's how these relationships occur. One of the interesting pieces behind this is if I'm the health network, if I'm Healthcare Partners, and I decide to tell the health plan, Blue Shield, okay, I will take on your members and care for them. I will make sure to care for them in such a way that you pay me the professional fee. In other words, the doctor's fees to deliver their care. But you know what? I'm going to take it a step further. If you're willing, Blue Shield, to do this with me, pay me for all the costs you assume it's going to take to care of this patient. That's including not only the professional fees that I need to pay my doctors, but also the facility fees to pay the hospitals, the hospital building itself, and everything that goes within it if these patients get admitted to the hospital. And so now these health networks, if they take on that, what's known as full risk, no longer, shared risk, but full risk. So now they're taking in the whole cost of care for these individuals. Their goal is to ensure great health outcomes in mitigating the cost of care, because in the end that impacts their bottom line. Okay, so what's in it for patients? Again, now we're all patients. Yeah.
Yeah, sorry to interrupt. I did have a question, and I wanted to come back about 2 slides ago.
Okay.
The question really reads, do any private insurance companies also partake in a 5-star rating system like Medicare Advantage plans?
Say that again. Sorry, Kelly, say that again.
Do any private insurance companies also partake in a 5-star rating system like Medicare Advantage?
Yes, they do. They absolutely do. They all kind of follow the same kind of algorithm or performance. And you're going to see it right now in a few minutes.
Awesome. And then another question, which you might come to, and when it comes to what's in it for patients, but Hayden asked the question, if a patient is a Medi-Medi, meaning Medicare and Medi-Cal or Medicaid beneficiary, what additional benefits do they have access to compared to just being enrolled in Medicare?
So the Medi-Medi patient, I'll answer this now. So the Medi-Medi patient depends. If they're strictly Medi-Medi and don't participate in a Medicare Advantage plan, just remember what we talked about. There's cost associated with that on the Medicare side. Now, if you have the Medicaid proportion of it, there's likely less cost that you're going to incur. But to me, here's the most important point. A Medi-Medi patient is the most complex of any patient there is. And so I would hope that we could see more, and this is my opinion, I would hope that we would see more of them in a structured Medicare Advantage plan, simply for the fact that we have the care navigation behind it. That Medicare component of the Medi-Medi allows us to tap into those financial resources to care navigate the most complex patient through the continuum of care. And for those of you who've had the pleasure of working in our clinics here at the FQHC, you've seen some of these patients. They're extremely complex, and you want to ensure that they don't get lost to follow-up or miss their appointments to their specialty care. So those are the benefits in my mind, and I hope I answered that question, but that's why I really think it's really critical to ensure that certain patients really tap into that care navigation, that care management piece, because that's a very underutilized and overlooked resource. Unless you're a primary care doctor, you could definitely appreciate those resources as an added benefit to your toolkit.
Sure. And just to also help clarify their hand, that beneficiary who's enrolled in both Medicare and Medicaid has the same access to benefits that any single enrollee does. So if, for instance, the Medicaid program in California offers coverage at a certain income level, they qualify for whatever that income level is because they're in the state of California, regardless if they're enrolled in Medicare or Medi-Medi. If Medicare, for example, is offering vision benefits, then even though they are enrolled in Medicaid, which may not offer vision benefits in their state, because they're a Medicare enrollee, they have access to those benefits. So beyond the idea of being a dual enrollee and having access to care navigation, just know that those same outlined set of benefits that's offered to any single enrollee is offered to that dual enrollee as well. Sean asked the question about ratings. Who actually determined these ratings? Is it patients?
CMS, the Center for Medicare and Medicaid Services, via an arm of the NCQA. There's so many acronyms, and I didn't want to like overwhelm you with those. But yes, it actually stems from a higher level of I guess, institution. So CMS generates that. CMS was a few years now, were the ones that put forth patient experience. They had solicited a non-for-profit to evaluate overall patient experience survey that took hold, and now there's multiple entities, but that they wanted to know what people were experiencing, right? Before, you never heard about that. We would never ask a patient, how was your doctor's appointment? And so I think those are just, again, based off of feedback and information sourced from certain patients, certain things have changed. But as it pertains to like the quality metrics, the metrics of managing a patient's health or preventative, that tends to come from evidence-based guidelines that are driven and put into place by these various institutions. Other questions?
Not right now, but keep them coming, folks. That's the point of this session.
All right. Again, this is something that we don't hear a lot about, so I appreciate the questions. That this is really important. This is an aspect of medicine that a lot of us don't get an opportunity to learn until we're in the field, until we're doing it outside of our residency training. So what's in it for patients if you're in a health network, IPA, HMO, right? So let's talk about that. Again, there's a lot of patient services and support. I can't stress this enough, right? Remember, the same things apply, right? So if these health networks are doing well, if they're managing their population well, there's a bottom line they get to keep, and then there's another percentage that they have to put in place to use for patient care. And so one of those is expansion of patient services and support, higher standards of quality. In other words, it's very visible. Again, they hold themselves to these HEDIS measures, these quality metrics via NCQA, via the CMS guidelines. And again, all this information is public. Folks, we don't appreciate some of this information, how public it is, but it is out there. It may be difficult to find, but after today, I'm sure you're going to be able to look it up and take a peek on some of these networks and their performances. But again, it's really important, and it's very valuable as a consumer to appreciate how well a network does in managing their thousands of patients. And one other point I'll make here, some of the nuances, again, if I'm a private doctor and I have a small medical office, I don't have the resources to call all my patients assigned to this health network if they're due for their mammogram or if they're due for their colorectal cancer screening. What the network will do, and this is something I did when I was an IPA medical director, was to ensure that I had a team to outreach to those patients and do the reminders and then help the PCPs so that they ensured that their patients got their screenings timely. So that's what I mean by reinvesting in and being part of that money-saving piece. But they have to use it correctly, not just to pay their shareholders. I mean, because remember, medicine is a business, but a proportion of those funds has to go directly to patient care in some aspect to better their overall health. So what's up with this public information? Well, here it is. And I'm sorry it's a little bit more compressed, but I wanted to take a screen of this website for you from the state. Here's strictly from the state of California, the Office of Patient Advocate. Okay, this is the website, the state of California Office of Patient Advocate. What you're looking on the screen, and this is just a snippet. There's lots of health networks, IPAs, HMOs. Remember, we talked about this. This is how they're getting rated from quality of medical care to overall experience. And so it's really interesting to go down this web page, and it's been updated, which is a lot more friendly, and hence why I couldn't screenshot it as well. But you could see a lot of familiar names that maybe at some point you'll run across and be like, hey, I know Hoag Medical Group. Look at how good or how bad they are, right? And this is the most updated information. But they're right there, right? You notice it's 5-star. This is not Medicare. Let me be very clear. This is not Medicare Advantage, but they're still using the same, description of overall performance. And you can see Kaiser there. From a quality perspective, it's 5-star. From a patient experience perspective, it's 4. You can see others that are really poor. I wanted to make sure I showed you guys that. But there are definitely, not every HMO, IPA health network is the same. And this is really important to appreciate when you look at this, because these are individuals, and these are all, let me also mention, what you're seeing here, these are all Orange County-based HMOs, okay? So that's another thing I wanted to kind of share. But you can kind of see over there on the top right, what are those ratings associated with, right? So asthma, diabetes control, cardiovascular, preventative care, children, and then overall, like, patient experience. Would you rate your doctor, from the infamous 0 to 10, health, communication, how good is your doctor communicating with you, timely care of access to services. All these are really important elements, and all this is publicly available. You just got to know where to find it. That's the other piece. So, what's in it for you? Okay, let's turn the roles here. Now we're all physicians. What's in it for me as a doctor? Well, I've kind of been giving you some of those examples, right? So now, you're opening up, like me, right? I opened up my own private office. How was I going to get patients? How was I going to be able to pay my rent, pay my staff, put food on the table? Well, I needed to contract with insurance companies. Yes, I could do directly with Blue Shield, Blue Cross, but also it wasn't a bad idea to enroll with these HMOs because they naturally would enroll and give me patients. And just like Medicare Advantage, they would assign me patients and pay me a monthly dollar amount if I saw them or not. And so that was just natural reoccurring revenue that I would see them. Again, we talked about the patient support, right? There's that care navigation piece, but also I mentioned earlier that there's that really neat piece of they would help me. They were an extension of my primary care space, right? So they would, offer to call my patients to make sure they come in for their preventative measures or their diabetes management, or more importantly, they decided to, in some cases, they would call my patients who needed breast cancer screening and told them to go direct. I didn't need to write an order. I didn't need to see them in person. They just would direct the patient to the imaging center that they contracted with so that they got their mammograms timely. We talked about higher standards of quality of care and value-based compensation. Again, in some instances, if I did really well in managing my panel of patients from the HMO, they would give me a bonus. They would ensure that I would get paid. And then that money, in turn, obviously, depending on your situation as a private office, you could reinvest it into the care of patients, or you could, reinvest it into more staffing, however you would be able to use that money. So that is kind of, a tour of the Medicare 101, the HMO managed care space, and really trying to appreciate this from a very unique lens, because to me, it's important as future healthcare providers, really, really important to try to appreciate every lens that healthcare is being looked through. From us as providers, as simply writing a prescription, to now handing it off to a senior patient who now has to figure out how they will pay for this prescription, especially if they're not structured in a way that they have good income. I think that's another really salient point that I wanted to make sure you all got. I think you got that. But I really hope, I hope you all learned something today. Open and taking questions. I know some of this stuff sometimes is really overwhelming. And trust me, it's taken me a long time. I'm not an expert, but it took me a while to really appreciate the nuances of this. So thank you.
So I hope this helped you understand not just the eligibility and alphabet soup of Medicare, but also what it looks like from a patient perspective in trying to access insurance. If someone's meant to enroll, eligibility is pretty immediate. It's not like you have to go through a lot to become eligible for Medicare. But now you know that it's a little bit more difficult to actually figure out where you want to put your dollars based on your needs and based on your financial situation. So I hope this gave you a little bit more of an overview. Because we're already into our next session's time, I'm going to encourage people to just ask questions in the chat, and as they come, then we can answer them. But I'm not going to dedicate true Q&A time to our last session, just so we can give time for Dr. Mayorga to move into his next topic. Is that okay? Okay.